Hello everyone, today we will move on to the next class, the flagellates. Till now you have studied the protozoa, amoeba which was motile with pseudopodia. Now we will move on to protozoans which are motile with their flagellae. Now these flagellates can be classified as either hemoflagellates or intestinal flagellates. They all belong to the class Zoomastigophora. They have one or more flagellae as their organ of locomotion. You can see I have shown three types of protozoan parasites here which have flagellae. The first one you can see, now you can see that the flagella is attached to a structure called as blepharoplast or also called as basal body or the kinetoplast. This structure contains mitochondrial DNA and it has the flagellae arises from a structure called as exoneme, and the part of the flagella which is free outside the protozoan parasite is called as the flagella. Now based on where this parabasal body or the kinetoplast is situated in the protozoan parasite, they can be antenuclear flagellae or postnuclear flagellae. Now in the first picture you are seeing something where the kinetoplast is to the anterior, rounded anterior end, that is antenuclear kinetoplast, and you can see a tuft of flagellae arising. One of the flagella has become a membrane and it comes out through the pointed posterior end. This membrane which is formed is called as the undulating membrane. In the second picture you can see that there is a single flagella which arises from the kinetoplast which is beyond, that is again post-nuclear kinetoplast, and it arises immediately outside, forms a very small undulating membrane and again enters the protozoa and comes out through the posterior pointed end. In the third picture you can see that the kinetoplast is based pre-nuclear kinetoplast, means it is very near to the posterior pointed end, and immediately from the exoneme, immediately the flagella arises from the exoneme and comes out of the protozoa. Now they can be either intestinal, oral or genital flagellates and blood or tissue flagellates. Now we will move on to intestinal flagellates. The most important human pathogen among the intestinal flagellates is the Giardia lamblia. It is also called as Giardia intestinalis or Giardia duodenalis. This Giardia is very common in all the tropical countries. Its habitat is duodenum, upper part of the jejunum, and it remains attached to the duodenal villi. Morphology of Giardia. This exists as a trophozoite and a cyst stage. Trophozoite is the motile stage and cyst is the non-motile stage. Trophozoite will be attached to the duodenal mucosa and it remains motile. Now coming to the trophozoite. It has the shape of a badminton racket, that is rounded anterior end and pointed posterior end. When seen from side it appears convex. So concavo-convex. The one end is rounded, the other end is deep inside. So it appears like a convex surface. That concave part of this has a suckling disc which attaches to the mucosa. The size of the trophozoite varies from 7 to 14 micrometers. It has 2 nuclei, 2 exostyles and 4 pairs of flagella. This is how it will look in the trichrome stain. You can see the badminton racket shaped Giardia trophozoite and 4 pairs of flagellae and the exoneme. The central line is the exoneme. Now coming to the cyst. Cyst is oval in shape, measures around 12 by 17 micrometers. This is how the cyst will look like. It has again 2 nuclei and a axoneme, but there is no flagella which is coming out. Now, life cycle of Giardia. Host is human host, single host. So, the encystation and excistation occurs in human host only. The infective form to humans is the cyst. In the trophozoite stage, parasite multiplies in the intestine by binary fission, and cysts and encystation of the trophozoite occurs and cysts are passed out. Yeah. During encystation, the cyst divides into two cysts. Yeah. Humans get infected by ingestion of the cyst. The moment cysts are ingested, within 30 minutes there is excistation. Once they pass out from the stomach and reach the duodenum, excistation occurs and they start multiplying. The cyst gives rise to true trophozoites, and trophozoites divide by binary fission, and large number of trophozoites are produced in the duodenum, which will attach to the duodenal mucosa. Yeah, look at this. Cyst is ingested. Excistation occurs in the duodenum within 30 minutes of ingestion and it becomes into a trophozoite. Trophozoite starts dividing by binary fission. These trophozoites which appear like concave suckling discs, they attach to the duodenal mucosa, and once the condition is not favorable, they again encyst. Each trophozoite becomes into a cyst and these cysts are passed into the stool. That is how the cycle continues. Yeah. So, cysts where what they can contaminate? They can contaminate the food and water which will be consumed. Now, pathogenicity. The risk factor for getting giardiasis, the condition is called as giardiasis. The risk factor for getting giardiasis is mainly unhygienic practices, old age and children, and immunodeficiency. With the help of this suckling disc, they attach to the duodenal mucosa and cause malabsorption. Malabsorption of fat is very common. It is called as steatorrhea. The other nutrients which are malabsorbed are vitamin B12 and vitamin A. Because of this, the patient may have persistent looseness of bowels, that is loose motion, and there may be a very mild lactose intolerance also. Now, what are the clinical features when these Giardia trophozoites are present in the duodenum? Many cases, around 60 to 70% of giardiasis are asymptomatic carriers. That means they will have the giardia cyst in their duodenum, and on and off they will be having this belching, bloating and all, and they will be passing cysts, asymptomatic. They may not have any major symptoms. Then there is a condition of acute giardiasis, wherein the patient will have severe abdominal pain, bloating, belching and diarrhea. This episode settles down. This is acute giardiasis. In chronic giardiasis, what happens? Such episodes keep repeating with foul smelling diarrhea, flatus, bleeding, belching. They keep repeating over more than 6 months. That is chronic giardiasis. Now coming to lab diagnosis. Microscopy or demonstration of either the cyst or the trophozoite is the gold standard in diagnosis of giardiasis. Fresh stool has to be observed for, and a wet mount may exhibit, if trophozoites are present, actively motile falling leaf motility is exhibited by the trophozoites of Giardia. The cyst may be observed in iodine wet mount. Pus cells and RBCs are never seen in this kind of stool. This is the difference between the diarrhea caused by entamoeba and that caused by Giardia. So, in Giardia it is more so of diarrhea rather than dysentery. RBCs are not there, so it is not dysentery. There you rule out dysentery, and pus cells are not there, so it is less likely that it is bacterial. So, it is not bacillary dysentery. So, bacillary dysentery and amoebic dysentery are ruled out when it is only loose motion and there are no pus cells and RBCs in the stool sample. Then we have that is about demonstration of the protozoa in the microscopy. We have intro test, which is a string test wherein a gelatin capsule is attached to a thread and it is swallowed by the patient. One end of the gelatin capsule is attached or it is stuck to the inner surface of the cheek, and the patient swallows this capsule. It is left into the duodenum. The length of the string is such that it reaches the duodenum and it remains there for 4 hours. After 4 hours, what happens? The gelatin would have got dissolved and the thread will be lying in the duodenum. So, it will absorb onto its surface all the duodenal secretion. After 4 hours, it is pulled out and it is rinsed into saline, and a wet mount can be made to observe the trophozoites, presence of the trophozoite. That is called as string test. Then a duodenal biopsy may also be performed and stained with Giemsa stain to demonstrate the trophozoites on the mucosa. We have antigen detection, wherein coproantigen, which is the antigen of the trophozoite, it can be detected by ELISA or direct immunofluorescence assay, or we have a ICT, that is a rapid cart immunochromatographic test. This ICT has a panel of protozoa which can detect, which has the antigens of Antamoeba, Giardia and Cryptosporidium. All can be detected in a single ICT. Then antibody detection, the antibodies are not specific, hence the antibody detection is not a specific test to diagnose. Now all this till now whatever I told, that is the microscopy or the string test or duodenal biopsy or antigen detection, they are all for diagnosis, not for therapeutic uses. For research we can do culture. Culture is done in Diamond's medium, and we also have now molecular tests like film array which detects a panel of protozoal diarrheal agents. Now coming to treatment. Metronidazole, tinidazole, nitazoxanide are used. Furazolidone is used in children and paramomycin can be used safely in pregnancy. Now we will move on to the next flagellate, that is the genital flagellate. Most important genital flagellate for humans is the trichomonas. Yeah. These are observed in diarrheic stools, may exhibit trophozoite phase, but there is no cystic phase. The trophozoite is a pear-shaped body, slightly bigger than our Giardia trophozoite, and it can have 3 to 5 anterior flagella that are free. Yeah. So there is no undulating membrane, all the flagellae are free. This is how the electron microscopic picture of trophozoite of Trichomonas vaginalis is seen. According to the habitat, they can be Trichomonas hominis, which is in the intestine, Trichomonas tenax also is in the intestine, Trichomonas vaginalis is in the vagina, or it is the genital flagellate. Now coming to Trichomonas vaginalis. You can see here it is a pear-shaped trophozoite with 4 to 5 free flagellae, tuft of flagellae at one end. This is how it will look. Yeah. Single oval nucleus at the anterior end, and the base is supported by rod like structure called as the costa, which comes out as exostyle, and a tuft of flagellae are seen at one end. The exostyle runs in the middle of the body and ends in a tail in the extremity. Now coming to the life cycle. Okay. Yeah. In the life cycle of Trichomonas also, we can see that there is no cystic stage. The asymptomatic females are the reservoirs of infection and transmit the disease by sexual route. The trophozoites divide by longitudinal binary fission, giving rise to a large number of daughter trophozoites. And again they will be present in the vaginal secretion, which will be transmitted to the partner. This is how the life cycle continues. Coming to the pathogenicity. Many patients are asymptomatic, and it is a very important sexually transmitted disease. Acute vulvovaginitis, in acute vulvovaginitis, large amount of Trichomonas vaginalis trophozoites are seen in the vaginal discharge. There may be white discharge which contain these trophozoites, and the vagina will be studded with punctate hemorrhages. So it appears like strawberry vagina. Other symptoms are dysuria and lower abdominal pain. In chronic trichomoniasis, there will be scanty white discharge, but it may lead to complications. Over a period of time, due to the presence of trophozoites of Trichomonas vaginalis, there may be pyosalpinx, endometritis, infertility, cervical erosions and low birth weight babies if pregnant women are infested with Trichomonas. In males, the male partner who gets it from the female partner, there will be urethritis. Lab diagnosis, again microscopy is the definitive diagnosis, demonstration of the trophozoite on wet mount is the definitive diagnosis. The white discharge can be stained using GIMSA, PAP or fluorescent, Papanicolo or fluorescent stain. Culture is again by Diamond's medium, modified Columbia agar, McCoy cell lines, but culture is not for diagnosis, it is only for research. For diagnosis we always do a demonstration of the trophozoite from the white discharge or the vaginal discharge. Antigen test by ICT or ELISA, antibody detection by ELISA are available. Molecular test by PCR and microfilm array is also available. Supplementary test, that is clinical diagnosis, can be made by increased vaginal pH and whiff test, that is increased ammoniacal levels in the vaginal discharge. That will give you a clue that it may be due to the vaginitis may be due to Trichomonas, and when we do a wet mount of the vaginal discharge we can see the trophozoites, that will confirm the diagnosis. Treatment, both the partners have to be treated, again metronidazole or tinidazole are the drugs of choice. So that ends your class.